I think they play a very important role. So certainly total knees have done very well over the years, and we're able to perform a total knee reliably, restore the physiologic axis, as well as maintain that with a high degree of accuracy and precision. That being said, there are 5 to 10% every year of total knees that fail, and a lot of times that's due to extra-articular causes such as lower extremity deformity. So I think that you do have to assess how the lower extremity deformity can play a role in maintaining alignment of your total knee replacement. So I think you have to treat every patient individually. Certainly, many patients that have painful knee arthritis will have a pre-existing foot and ankle deformity. I think it's important to be aware of that before the surgery, specifically a deformity that extends all the way through the hindfoot, and then to know specifically is that flexible or is it rigid. And then post-operatively, certainly be aware of that. And there are many patients that may have pain after total knee replacement. Certainly that can be coming from any type of deformity, malalignment. If you have more of a flexible deformity, sometimes you can treat with some type of shoe modification, an orthotic or bracing. At some point, if and when that becomes symptomatic, that might require actual further reconstruction of the foot or ankle. No, I think you always try to work non-operatively first. Certainly shoe modification, some type of arch support, orthotic, potentially some type of ankle foot orthotic or brace can accommodate the patient well. If that doesn't happen, if that doesn't accommodate the patient enough and they become symptomatic down the road, certainly surgical intervention can be indicated at that time. That's a great question. I don't think there's any consensus in the literature. I think overall you treat every patient individually. So certainly if you decide which joint hurts more. So many times patients will come into the office, they'll have a painful knee and painful knee arthritis for a total knee replacement, and all of a sudden if you tell them they're going to have a foot procedure, they're not going to be very happy. So certainly you want to address the painful joint first. That being said, typically just by doing a total knee replacement, that can correct up to 50% of the lower extremity deformity. So sometimes that's enough, and then you can put them in orthotics, some type of shoe wear modification that can be satisfactory for the lower extremity. That being said, if both joints are painful at the same time, both joints are symptomatic, again, I would recommend performing the total knee replacement first. In general, you want to go proximal to distal. You restore the mechanical access to the knee. Then you can realign the hindfoot if need be later on to that knee. And that being said, again, just by correcting the knee, you can correct about 50% of the hindfoot malalignment. I think that's on a case-by-case basis. So again, I think you do the knee deformity first. You try and accommodate for any foot and ankle deformity, and then you see if they become symptomatic. Sometimes they won't become symptomatic, and so you'll be able to accommodate them with just the shoe modification. I think at some point when they do become symptomatic and painful, then you can consider additional reconstruction. That being said, if both are severely painful, I would usually like my total knee replacement patient to really be up and going. So I'd probably wait at least 3 months until they're very active and independent, because the foot and ankle reconstruction, unlike a total knee replacement, unfortunately there is a prolonged period of non-weight bearing. So sometimes 6 weeks, sometimes even 10 weeks, so that's a much longer period. You want to make sure that knee is active, good range of motion, good strength, the patients are ambulating well before they'd have to undergo a recovery for the foot and ankle procedure.